Well, I really appreciate you guys this semester helping me out and everything. Well, I'm going to do a little presentation about stroke recognition and patient education. The education part will be sprinkled in. So, it's a slide presentation. Did you guys feel like you did okay on the pretest?
Yes.
Okay, good, good. So hopefully we'll cover those in the presentation. And then also, the learning objectives we're going to cover will be to recognize the risk factors for stroke. We're going to discuss the pathophysiology of stroke, identify differences between a TIA, an ischemic stroke, and a hemorrhagic stroke, discuss medication and surgical therapy, and also nursing diagnosis that you see associated with a stroke patient. So first, some basic statistics about stroke, which are located in your wonderful textbook. I think it's very interesting that there are 160,000 deaths in the U.S. alone. That's significant. I think you got, there's a pretest and some learning objectives. We just got started. We didn't miss much. And just some basic statistics. Anybody want to contribute anything about that? Okay. So, the etiology, basically there's non-modifiable and modifiable risk factors. Can someone name some non-modifiable risk factors?
Race,
Age,
gender,
Family history.
So more men have strokes because more women die. Why do you think that is?
because we live longer.
What's another reason?
They
Something
said
that's just-
because of the human,
Postmenopause?
no, because they said because the hemorrhagic stroke causes in women, it happens so fast that when it happens, it just happens.
Yeah, it's pretty. Well, another thing is that we have smaller blood vessels. So when you think about it, there's little room for plaque formation. I mean, the little plaque formation that may not just have a big effect on a man will have more on a woman. So that's interesting. Well, modifiable risk factors, you name some of those.
Sedentary lifestyle. Hypertension.
Poor diet.
Something I found interesting.
AFib.
Exactly. Hypertension is the single most important modifiable risk factor. So you want to get your patient, if you have a patient who is borderline or hypertensive or family history, you kind of want to be giving them an idea, as you get older, you may want to really try and pay really close attention to that because, you're at more risk for a stroke with your hypertension. And AFib is a treatable heart condition. You can receive treatment for that, decrease the chances of a stroke as well if they get that treatment. So pathophysiology, basically, the brain, the blood is circulated two pathways. You have your carotid and vertebral. So the carotid is your anterior, the front part of the brain, and then the vertebral is your posterior things. And regulation of blood flow, that's really important because we have questions about that. So basically, this is kind of hard for me to explain, like, gets me all confused. But blood flow that's interrupted, which happens in a stroke, metabolism in the brain occurs within 30 seconds, and then within 2 minutes it stops, and then there's ischemia. COTs, carbon dioxide levels, are extremely important, and has a dramatic effect on cerebral blood flow. So that's a very important factor because CO2 and oxygen have an inverse relationship. If you look at like a blood gas, someone's CO2 is really high, most likely your oxygen low. So if your CO2 goes really high in your brain, you're going to do that's more oxygen deprivation, more death. So that's a single most probably contributing factor. Also, other things would be cardiac output. You need 20% at least to keep your brain functioning. You need 20% cardiac output. And collateral circulation, atherosclerosis, and ICP also affect increase in intracranial pressure will affect your blood TIA briefly, that's like a temporary loss. Most of them last less than 24 hours, but also less than 15 minutes. So it's like a temporary. You may have like right-sided paralysis. You may feel like, you know, you have apoptosis, your eyes like droopy, or, you know, or something. So this is a big warning sign for the fact that you're probably going to have a stroke. So this person who presents with this, you know, in the clinic or something, you want to get them over to the ER because they probably need to start some kind of medication to help clot formation, break up the clots, or whatever is going on. They needed to address it. So, and also with the TIA, you want to make sure they have a CT scan without contrast. I mean, that's a very important diagnostic feature. Carotid involvement would be the loss of vision in one eye, and then the vertebral bacilla would be the tinnitus, the vertigo, the ptosis, you know, whichever side it occurs on the brain. So ischemic stroke would be the inadequate blood flow to the brain from partial or complete occlusions of an artery. So there's pretty much two that fall under there. Would be the thrombotic, which is an injury to a blood vessel wall, formation of blood clot. Something really important with the thrombotic is it has a big increased association with diabetes and hypertension. These symptoms increase like, gradually you find yourself less able to carry out your motor function, basic skills, and you may have the right-sided or just all basically the same symptoms you will have with TIA. It's really important for these patients to get the diagnostic studies, the CT scan, to determine, because, you know, most of them kind of present the same way. You know, you may have dysphagia, you know, or, you know, ataxia. So you really have to get into these things and evaluate. The embolytic, so the embolus lodges and occludes a cerebral artery, resulting in an infarction and edema of the area supplied by the involved vessel. So an important thing to consider with that is that most of them originate in the heart. There are some that originate in the long bones, but for the most part, these are a rapid onset of symptoms. So, and then also I found interesting that these patients present conscious. It has few warning signs, so there's nothing that shows them that it's impending. You know, that's kind of scary. Anybody have any comments or anything? Okay. So our hemorrhagic stroke would be the bleeding into the brain itself that is intracerebral and also subarachnoid is the rupture of a vessel. Hypertension is a major causative factor. So, you know, again, educating, you know, your patient who has not had a stroke but has hypertension, you may want to talk to them about, you know, a stroke is brain damage, and you don't want to lose the ability to walk and eat, and, you know, feed yourself. You know, I don't mean to scare your patient, but you want to tell them about what things could possibly take place. That's very important. And there's subarachnoid, is the intracranial bleeding into the cerebral spinal fluid fills space between the arachnoid and the pia mater. So it's the surface of the brain, and the subarachnoid bleeds are not good. And so this would be your patient who has the most severe headache of their life, visiting people who like it could, I mean, just and the severe nausea and vomiting, and the rapid onset of symptoms. So you can kind of get a gauge when a person presents, like if you're in the ER. Who was it last week that had the patient who had the possible stroke? Okay. Okay. And so did they ever determine? Did you ever hear anything? Okay. But he fell when he blacked out, and then
His coworkers found him.
okay. Okay.
But by the time he got back to the ER, he was coming back to himself.
Yeah. Okay. Interesting. So maybe he had TIA. Warning stroke, like, and he probably got him like where, you know, hey, I need to get my medication straight or whatever. And it's with one of one of the things, you know, if the person with pons, that's your basic life functions. I mean, if you have a pon bleed, then, so, here's that. I found this stroke recognition algorithm on this website, and it's fast, and basically, as a preliminary, if you have a patient who is, like, you're talking about patients who are sick, or may, you know, have hypertension or diabetes and all these other indicators of possible stroke. It's good to teach them like an algorithm or something quick so that they recognize, because, you know, time saved is brain saved. So if you have a person, you know, some older people are kind of, they don't really want to go to the doctor. I don't want to go. And they waste time, and they, oh, wait, I'm going to call my family. You know, be on top of it, because if you can get them to understand that, hey, look, if you do happen to have any symptoms, the faster we get you there, the better the chances, your outcome, and your lifestyle will be. So it's a good one. I like it. It was really quick and to the point. Your face, your uneven smile, your droop, numbness, weakness, numbness, difficulty walking, your speech, slurred, inappropriate words when you. So time is critical.
What website did you get it from? What's the website?
It's the actual is on. I gave you a paper. It's referenced right at the bottom. Yep, it's really good. A lot of information. So your clinical manifestations are vary depending upon where your stroke occurred, but your motor functions, gag, swallow, speech, communication. Now, I wanted to talk about those because I was like, wow, that was like, you know, news I could use, so to speak. You know, a cheat sheet. So the aphasia is when a loss of comprehension of use of speech, so they have nothing, total. And then your dysphasia is your difficulty, and then the dysarthria is when they, it's kind of like they don't have control, so they may, you know, and then, you know, it's kind of have like a weird speech. And then I found this interesting. Well, of course, intellectual function, and that's really sad. Is the spatial alterations. You mainly see that when they have it on the right side, because that's your ability is affected on the left. You know, they would have. So and also elimination. Some people may lose the ability to, you know, become, you know, they lose continence. And so diagnostic studies. These patients would have a CT without contrast media, would identify the site and size and determine if it's which type is it hemorrhagic, is it ischemic, because again, these patients may present with similar symptoms, and the MRI to determine how much injury, how much brain do we have left, is it, you know, whatever's going to happen, and then your cerebral and geography, which would show the occlusion, the plaque, and if there's some kind of malformation of the vessel. Additional studies, you would probably do a cardiac workup. You're going to do your chest X-ray, there, have EKG, and our job would be to prepare the patient for these things. In some places, you actually do it to look at EKG yourself. There's no person. And then, of course, you draw your blood. You're going to use CBC. You have platelets. I mean, this is a very aggressive therapy, and it's time, so you're going to be doing really fast. And so your drug therapy and sorry about that. For a person with an ischemic stroke, you're going to do the TPA. What do you know about that, Letitia?
It should be administered within 3 hours of the stroke.
Right. And which patients are not supposed to?
Hemorrhagic stroke. Hemorrhagic.
And so what tests do you do also, you know, to find out preliminary, we just talked about
CT
without contrast.
Yeah.
Without contrast.
And they do different stuff too, also. They got to do
Exactly.
further testing to
Exactly.
make sure they haven't had any heparin or
Exactly.
plate.
So, you know, you'd be getting a PT, you know, and all that, your
they call the
And then
code.
went and got a CT scan within 5 minutes.
Awesome.
Is that the one that they call the code team on? The stroke, code stroke
Yeah.
on? Yeah.
Yeah. I know most hospitals have like a system in place where it's very aggressively and methodically approached. Like they it's do this, this, this at this time, this time, this time, and then there's people there that may even have like just all types of just
Yeah,
extra.
Yeah.
Exactly.
Yeah,
Exactly.
For
yeah.
Exactly.
25 minutes, then 45 minutes to read your
Yeah.
Excellent. So, I got these from your book also, some good nurse diagnosis, ineffective tissue perfusion related to decreased cerebral blood flow. Okay, you can, but, just some nurse diagnosis based upon that. And so long term, one of the things I really wanted to highlight, because we all know, you guys have been reading about it, you just took a test over stroke. So long term, these are people who need rehab, maybe more surgery, maybe PT, OT, that's rehab, and a lot of one-on-one care. But I think something that's ignored commonly is how in-person emotional or mental evaluation, because they may have lost all ability, and this is someone who's been independent and functioning, and then they don't have it, and I think that set that person up for depression, even if it's a really strong person and they have a lot of help and a lot of family support. It can be really hard, so I really wanted to highlight that, in terms of you as the nurse, of course you would address all of their physical needs, but also, talk to your patients and communicate with them. And even if someone can't communicate, they can probably hear. And that's, talk to them, reassure them, let them know, you're there. And I think that's important. That's something that I really wanted to.
You feel trapped inside of it.
Yeah, you're a prisoner. You basically
Your own
went
body.
you went from function to maybe total dysfunction. I have
Back to a baby.
exactly, I was just talking to Ms. Ford about my friend, her mother just had a stroke, and this was a lady 2 days prior to the stroke. She was totally fine. Just totally fine, and she had a spinal cord, and so she was on a vent. She was a total, it looked like, when I saw her from just a nursing standpoint, and I'm a total baby nurse, PD nurse, I was like, oh my God, I hope she regains something. And I got a text from my friend yesterday, and her mom is walking with a cane, walker, and she was extubated, she did a little nasal cannula, and they took her off that, and now she's regaining some ability to talk. And she doesn't sound, because initially it was like mush mouth, but now, and I was like, thank God, but yeah, but one of the things I can say, just as I put myself like as a friend and as a nurse, is to talk to the family and communicate and make sure, like I just mentioned, it's a really good thing. So here are my references, and I just want to tell y'all thank you for being patient and listening to me.
Thank you.
Thank you.
Thank you.
Any questions?
Yeah, you guys have